I'm also supposed to give the tech people some advance time before we go live, because we are going live.
Have to behave.
All right, great. So we are talking about health reform and the health reform debate. And as will become very evident, those are two very different things. That is, the things that need to be fixed and the things that we think we're fixing, and the things that we're talking about fixing don't have a whole lot of overlap with each other, which is why the debate in Washington is not something just to be listened to, but we should have a debate here as well. And we have a fantastic panel today. These three are, I have to say, representative of a lot of what we have here at Duke, a lot of really exceptional experts in the world of health policy, with a lot of really great ideas for health reform. The three panelists are Kevin Schulman, who is a professor of business administration and one of the associate directors of Duke Clinical DCRRI Research Institute. And he also heads the health sector management program at Fuqua. I have Don Taylor, who is a professor in public policy, and Clark Havighurst, who I will not call him an emeritus professor. I will a professor of law, who very much, whose intellectual breadth still has a great, has a remarkable presence here. I'm going to ask one question to all three panelists. Will give their answer, and then we'll open up to questions, because this will be very much an exchange. The question I'm going to ask is, what in our health system needs to be reformed, and are we on the way to reforming it?
Okay. Well, let me start off by setting a scene, and I'm going to assume most of you don't know much about healthcare in the United States. So I'll just spew out a couple of facts and figures. But healthcare is roughly 17 or 18% of gross domestic product in the United States. About $2 trillion a year is spent on healthcare. With that, the healthcare economy alone in the United States is twice the size of the GDP in India. It's bigger than the economy of Brazil, and probably is about half the size of the economy of China. Okay, so healthcare is a big industry in the U.S. Healthcare is incredibly expensive. That's how we get to 17% of GDP. The United States spends more money on healthcare than any other country in the world on a percent of GDP basis and also on a per capita basis. The cost this year for healthcare for each individual in the United States is on the order of around $7,000 a year. If the minimum wage is about $12,000 or $13,000 a year, you might imagine that some people who are not the highest wage earners may not have an ability to pay $7,000 on average for health care. And that's the other statistic that we have, that there are roughly 50 million people in the United States, or about 15% of the population, that don't have access to health insurance, and there might be another 50 million people who are underinsured. They have access to health insurance, but actually a study out of Harvard looked at personal bankruptcy in the days when we used to own our houses, and found that about half of personal bankruptcies were related to health care, and a lot of those were people who had insurance, but that insurance wasn't enough to cover whatever the cost of health care were. So that's some of the issues that we're dealing with. So what is the healthcare reform debate? So one clearly is, people who don't have access to insurance, can we get them access to insurance? In a lot of countries in the world, the health care is a right. In the United States, to some extent, we're having a debate over that. Historically, we didn't say that health care was a right. For every American, we have some statutory areas where you can get access to emergency services, but it's not in the Constitution that health care is a right. And that's a question for us as a society. Do we want everyone to have access to health care? When President Obama campaigned in the fall, he said that the reason why people don't have health care is that it's too expensive. It's too expensive on aggregate, and also the value of health care may not be as high as the cost of health care. And so his proposition was that we should work on reducing the cost of health care for the insured. Now, it's interesting, the Republican pollsters' take on this is that health care is a huge issue as well for the middle class for two reasons. One is that it's linked to employment. And if you lose your job, you lose access to insurance, obviously an issue with 10% unemployed. And then the second thing is the cost-sharing provisions of healthcare. Even if you have insurance, again, your out-of-pocket cost to go to the doctor, go to the hospital, to get chemotherapy drugs might be incredibly high. And so there's a cost issue that's hitting the middle class. And so actually both the Democrats and Republicans have argued on that. The third issue is an issue of sustainability. There's a person named Peter Orszag, who's currently the head of the Office of Management and Budget, used to be head of the Congressional Budget Office, spent 5 years at CBO looking at the future of Medicare and Social Security, and realized that we don't have any money to pay for these programs, these entitlement programs that are already on the books. By 2030, nominally, Medicare and Social Security, just from the federal perspective, are going to be $2 trillion a year underfunded. There's a projected shortfall of 5% of GDP just for those two programs without anything new and without Medicaid. And then the fourth is prevention. In case you haven't noticed as you're eating your burritos that there's an epidemic of obesity in the United States. You could have had salad, but you didn't. And the rest of you are drinking Coke products. So we need to do something to improve our health, because if we allow the population, and especially school-age kids, to continue with their obesity, they will get diabetes, they will have the complications of diabetes and be incredibly expensive. Things like sidewalks, nutrition in schools, activity are all things that might be linked to that. And there might be some relationship to what kind of food should we eat. We don't really have really good evidence about what food may or may not be related to health. So those are the four reforms that we need in the United States, kind of like China, the four reforms. The healthcare debate in Washington, of all those four, the healthcare debate started with access to health insurance. At times it stumbled into a little teeny bit the cost of healthcare, and mostly has ignored the issue about sustainability of the program, and mostly has ignored the issue about prevention. There's a couple little things in there, depending which version of the bill. The process itself of how we're going from the president's idea of having healthcare reform to having a piece of legislation is a lesson in civics. I'll leave that to you guys to explain to the American public why we went through this tortuous process. When you gave a talk in China in June, and they didn't understand why, when President Obama said, we want health reform, it just doesn't happen. But part of that process of going from the president having an idea and outlining these four ideas of what's wrong with the system is that all the tough ones are the ones that have been eliminated progressively. And so the House, the version of the bill that was just passed by the House has almost no teeth in it. So we're going to spend $100 billion a year more on health care in the United States to get access to health insurance for some of the people that are currently uninsured, not including illegal immigrants, who are 13 million people in the United States, and making some small changes to the system. But all of the other reforms that we needed are potentially being left for a later day.
Yeah, so that was a good overview, and I thought Kevin did a good job. I guess I would just say, if we were thinking about what's the problem, I would say the biggest problem is that the system is unsustainable due to costs. So there's a related problem that is the lack of access to health insurance coverage. They're not the same problem, but they are related. I would just point out one thing that I think sits at the heart of how we manage to spend our way to the situation where we do spend just about $2 every time most of our countries that we trade with and our allies spend $1, but we manage to have really pretty similar outcomes. And that is what's called the tax exclusion of employer-paid insurance premiums. And so that is a $250 billion per year subsidy by the federal government of people with private health insurance like me. So when Duke pays my health insurance premiums, they're paying about $600 a month for my wife, myself, and my 3 kids to have insurance. So 600 times 12 is $7,200 a year in tax-free income that I get from working at Duke. If you're uninsured, you get 0 tax-free income for health insurance. I would agree with Kevin that the House bill is mostly an insurance bill, meaning it would expand insurance coverage. I think in many ways the insurance exchange setups make a lot of sense. That they probably are pretty reasonable, but there's very little that you could look at in that bill that passed on Saturday night and say that's going to slow down healthcare costs. You could revolutionize that with one amendment, which would be to repeal the tax exclusion for employer-paid health insurance premiums. And if you did that, an argument would go something like this. There would be a fight over whether that was an an income tax increase, or whether it was the closing of a tax loophole. And what I would say, that's sort of like arguing whether it's a tomato or a tomato. It's a juicy red vegetable that's nice on pasta. So whatever you call it, if you did that, that will slow down healthcare inflation. And the worst part about this subsidy is that most people that receive it don't even understand that they get it. And so if you think of the cultural discussion of, my husband got a job with great benefits, what in the end that really means is somebody else is paying the cost. And so the way we got to this was not some nefarious plot. During World War II, we had wage and price controls in the economy. Large employers said to Congress, we'd like to compete for employees. Will you create something called a benefit, which means we can pay insurance premiums on their behalf, but it will not be counted as taxable income? Congress said yes. We've been doing that for 65 years. And that would be the simplest thing to have a chance to slow down healthcare cost inflation in the non-elderly part of the system. If I could do one thing for the Medicare program, I would create a Medicare commission that did have teeth. And what you'd have to do with that is I would submit that Congress is incapable of making the hard decisions to change Medicare. Politically, they cannot do it. So if you had a Medicare commission, you could structure it along the lines of a base closing commission where a group of non-governmental experts would say, here's A, B, C, D, E, F, G, and Congress would have to take the slate up or down. If we did that, we could also we could take the exact same bill, do those two things, and we'd be in business for slowing down healthcare cost inflation. I realize it's really simple for me to sit here and say that because I don't have to run for re-election as assistant professor. Well, actually, I do, sort of. I'm being reviewed for tenure, but that's a different story. But Kevin doesn't have to run for re-election as professor, so it's very difficult to change some of these the way we do things because people have gotten used to them. So. I think Kevin set up, there are a lot of issues that aren't being addressed. What passed in the House is really, if you look at the uninsured, there are three things you can do. You can do nothing. You can cover people with government insurance, or you can say we're going to leave the system we've got alone and try to cobble people in, essentially the back door. And we're doing the third. And it's going to be messy, tricky, not work perfectly. There'll be unintended consequences, but if you don't like option 3, see options 1 and 2. Do nothing or cover everybody with government insurance.
Okay, what's wrong with American health care? Well, there are lots of things. They usually are discussed under the headings access, cost, and quality. And there's no question we need to reform the system somehow. And Barak Richman and I wrote a piece a couple of years ago, a very extensive critique of the system that takes a little different line than you usually hear. We didn't focus on access, cost, and quality, but instead identified another issue, which was distributive fairness, and we call that the fourth dimension of American health policy, along with access, cost, and quality, thinking that how the costs of this system are shared among the population should bear some relationship to distributive fairness. I don't mean there should be redistribution necessarily from the rich to the poor, but certainly it shouldn't be redistribution from the poor to the rich. And we found a lot of evidence of just that. The paper is called Distributive Injustices in American Healthcare, and it's we got a tribute from email the other day. Some guy said he'd read that paper. It's the best thing on economics he'd ever read on any subject. And who he was, I have no clue. But he must be really observant and so on. Anyway, I want to recommend the piece. It's quite long, but it's well documented. The thesis there was that most Americans are being forced to pay too much for coverage that doesn't suit their particular circumstances, and they are in the process unduly enriching a very powerful industry in which monopoly, which has extraordinary redistributive tendencies here, more than we find monopoly anywhere else. Both Richman and I are antitrust teachers, and we have some insights about the importance of monopoly in the presence of health insurance. At any event, we think that this industry is ripping us off, to coin a phrase. That's where a big part of our problem lies. We also thought we saw ways in which lower and middle income premium payers are themselves subsidizing higher income coworkers in the same health plan, that they're putting the same amount of money in premiums but getting less out of the plan, and therefore that seemed to us unfair. We argued that more generally, that industry interests and these elite consumers, the folks who make policy, everybody in a high income bracket, have tended to foster a legal and regulatory environment that denies ordinary consumers opportunities to economize in purchasing health coverage, health care, and that is the source of our problems. And my concern is that Obamacare will be even more unfair in its treatment of these lower and middle income premium payers. And if the Democrats will always tell you they care about the poor, ordinary working American, but I don't see much evidence of it in the way this program is being designed. Now, I've always thought that the ideal health policy in the U.S. ought to feature private health plans competing to give Americans good value for what they have to spend and want to spend on health care as opposed to other things. And, of course, there should be some form of public subsidy, possibly vouchers that would allow those who can't pay the full cost of decent health coverage to get it nevertheless. We haven't had that in the past. Instead, we've had a system that's not allowed people the room to economize I've referred to. We've given people, in effect, a Hobson's choice. You either take the coverage that the system says you must have, or you go without coverage altogether. And that coverage is very costly. It costs a family, and on average, over $13,000 a year. And if you think about it, families of earning 40, 50, 60,000, that's just unthinkable as a way to make them spend their money, and they should have options. Recently, of course, powerful forces have become concerned that too many people are choosing the second of the Hobson choices, choosing to go without coverage. And the liberals, of course, see the hardship of the uninsureds, and they want everybody to have what they have, and that's partly what's driving this system. The Democrats, however, are writing this reform legislation really, I think, to gain for themselves a place in history as the authors of a legislative capstone on the American welfare state, and nothing will stand in their way, nothing that I can see in terms of the future of the economy, the effects on the working class, anything else. I must say, I'm not impressed by their good intentions. Anyway, also pushing for reform, of course, are, at least if they can get it on their terms, is the healthcare industry, which sees more and more patients that aren't able to pay for the costly care that they really want, that this industry wants to provide. And the industry interests are strongly attracted by the prospect of having everybody have a have health insurance as a deep pocket so they can afford what the system wants to do. And the President has, in order to get the industry's support, has struck some deals. I have the word unsavory here to describe those deals. with powerful interest groups. Okay? Health insurers, the AMA, hospitals, drug and device manufacturers, they've all said, we'll give up a little bit, but we really want everybody we deal with to be insured so we can exploit our monopolies to the maximum. And nobody has called him on this really, I think, serious selling out of the interests of the very consumers they claim to represent to industry interests. An implicit part of the deal seems to be that the private health plans won't be given any new powers, will still be in a position where they can't really control the cost of care in order to make it affordable by ordinary consumers. The pending bills will leave the plans to do little more than just administer a publicly designed program and helping working people get a better deal in changing care is just not part of the agenda here. And I think the Democrats are fully prepared, if they can get away with it, to impose new financial burdens on working people in order to achieve their historical mission. Now, how have we gotten to this point? Don's made this point, but I want to repeat it. The main reason health care costs so much in the U.S. compared to every other nation, and we aren't talking about just a little more, we're talking about whole percentage points of GDP, 3-4 percentage points of GDP being spent on health care in America, which could be spent on other things. And it is not just a marginal concern. This is big time spending. Seems to me the source of the problem is the tax system that's long effectively hidden the costs from those who bear them. And as Don says, the problem is that the value of employer purchase coverage is not treated as taxable income to employees. The most obvious effect is that people then want to buy very comprehensive coverage in order that they can pay everything from dental bills to vision care with pre-tax rather than after-tax dollars. So you've got coverage that was designed to really remove the cost factor in most decisions to consume anything related to health care. It's my observation that there's a more important effect, however, from this tax subsidy. And because the employers pay for their coverage, the workers tend to believe that the cost is paid by somebody else, their employers, not by themselves. And whereas economists will tell you that the cost does fall on the worker in the form of lower wages, and Don indicated this, lower wages, fewer other benefits. This is a very insidious fact. The illusion that someone else is paying for their health care has caused Americans systematically to favor both as consumers, and this is important, and as voters, more and better health care. Any very generous coverage, any measure that seems to improve the quality of care and is very much supported by the American who doesn't understand his stakes in the political game. Employers and unions have played the workers' ignorance to the hilt. They have said, look, we just care so much about you. Here's some health benefits, of course, that's being paid for by the workers themselves. But it makes the labor unions leaders look good. It makes employers look like really caring employers, but it's all a fraud. And the tax subsidy is part of that. It means we have generous coverage. We have voters supporting things that aren't in their interest, in fact, contrary to their interests. And it also, the distorted perceptions have also created what I think we can call a cultural paradigm under which everybody seems to believe, at least nobody wants to deny it publicly, that health care is so special that it should always be paid for, whatever its cost, if there's some chance that a patient might benefit. Again and again, one sees people unwilling to do face trade-offs between cost and benefits. Cost-benefit trade-offs are not relevant in making decisions about health coverage and health care in the United States. Now, I hope that we can have a little time to talk about some specific things that in these reforms as they're taking shape that will, in my view, sock it even harder to the working Americans whom the so-called progressives seem always have claimed to care most about. I got a list of them, but we can go through them
let me,
at some point.
Go for it.
Yeah, let me maybe rebut. Well, Clark and I don't disagree at all that the healthcare system's broken, but let me try and push. He's using some really strong rhetoric, and let me maybe try and push him and push us all.
Getting old and impatient.
I noticed that. Clark's been trying to fix the system for 40 years. He's actually most people have. So let me break this up into a couple different components. So we've heard about something about the tax system. We've heard something about Congress and can Congress fix this. And let me just tell you, at one level, what we're having a debate about is our political economy. What is the role of Congress? What is the role of the government in organizing our future? Because here's 20% of the economy totally in bed with the government. Half of the spending is from the government. All of us think it's not good value. And yet a lot of people are making a lot of money from the system. And can we change that? Can we get, when all of you guys go out and go to K Street and lobby, you wonder where your income's coming from. It's coming from the drug and device manufacturers and the health insurance companies. And so we have a system where the Congress is not disinterested from commercial interests in making policy. And even when that policy either adversely impacts the individual workers or adversely impacts our competitiveness vis-a-vis the people we trade with, like China. There's a reason why jobs are going to China. It doesn't cost us a lot to have health insurance for workers in China. There's a guy in Durham who I have a story. He had 1,500 people working here. His health insurance premium went up by $1,000 a person. He moved them all to China because it only cost $1,000 to employ people in China to do textiles for the full year, let alone their health insurance costs. So this is to some extent a plebiscite on the future of the role of government and a pretty fundamental part of our economy. And then the second issue, I'll take a snipe at both Don and Clark. So health economists hate health insurance. Right? All the evils of the world are health insurance. And there's a reason why, going back to Kenneth Arrow's Nobel Prize in Economics on moral hazard, we become much less fastidious consumers when we use other people's money. So the law school bought your burritos. You guys all got the beef and chicken instead of the veggie one because it was cheaper because the law school bought it. That's moral hazard. It got Kenneth Arrow the Nobel Prize. So health insurance has always been held out. This tax exclusion of health insurance is held out as an evil in the United States. The only thing is it's a total fallacy because, you know what? The UK has national health insurance. And instead of paying a premium, you pay a tax. And France has national health insurance. Instead of paying a premium, you pay a tax. And somehow, even with everyone having health insurance, their health care costs are half or less than the United States. So while you're right, in terms of building up to where we are, there's something about third-party payment that made us less good consumers. Somehow other people have been able to do third-party payment and not been as terrible consumers at the same time. So it's not just the tax. And in fact, here we are arguing that access to insurance is now this public good, right? We want all the poor people to have access to cancer chemotherapy, the same as the rest of us have to do. So there's something else within our system that's not the tax code that drove us to this incredibly inefficient model. And to some extent, that's more the political economy of healthcare. You know, the fact that when we over-reimburse radiologists to do imaging, we don't change it. I'm reviewing a paper right now where the Congress, when they changed the payment for cancer chemotherapy drugs, the payment that they were making was about $2,000 a dose for this one particular drug based on a regulatory scheme that they come up with payment. When they changed the scheme, the payment went from $2,000 a dose to $200 a dose. And the GAO and several other organizations had commented on this for years and years and years. We're overpaying for this therapy. It was about 8 years until they changed it because the people who were making $1,800 a dose were really happy with the payments they were getting. That's not how the UK is running their National Health Service. That's not how it works in France. So I empathize with the fact that health insurance is this evil, this unique evil that's perpetrated on society, but we're the ones who have this uniquely flawed system, despite the fact that that other people have health insurance.
You guys want to swipe back?
I'd like to respond. I think health insurance is fine. I mean, I don't hate it at all. And I think moral hazard is a problem, but it's a problem that can be managed. A certain amount of moral hazard is completely acceptable as part of the cost of having pooled your risks and being more secure financially about healthcare problems that may result. Okay, so a bit of moral hazard is fine, all right? And people indeed get insurance, so they won't have to count the nickels and worry about the trade-offs with their children's food and shelter in buying health care. So they get insurance for that. And so the little moral hazard is introduced. Moral hazard is fine in the appropriate amounts. The problem is we have turned it loose so that it is pervasive in its effects. And the alternative would be to have health plans in a position to control moral hazard, to treat the premium pool as a fund in which everybody's put some money and they have some rules as to who can take it out for what purpose. And once you see health insurance in that way, it becomes a pretty benign undertaking. We're helping people get value for the money that they put in this pool. Now, nobody thinks of health insurers that way. They think of them as rapacious, profit-hungry claims deniers. But if you think of it in this other way, it has a perfectly benign function. And indeed, our problem is that we have so circumscribed what health plans can do about in rationing care, rationing financing. They don't ration care. They only ration when you can take the plan's money for a certain purpose. You can get the care if you want it and can afford to pay for it some other way. They can't design, they haven't designed coverage to meet people's trade-off between some moral hazard and the health care that you need. Ultimately, the reason we have this kind of health insurance that doesn't control for moral hazard is the tax subsidy. People haven't understood that they had a stake in this game. That they're putting their money in a pool and that premiums will be lower if the plan can ration. They don't see that the premiums are being paid by them, so they don't take an interest. Don is right that changing the tax subsidy could do wonderful things, and it would do something to the political economy of this country by making consumers for the first time aware that they are paying their money for this really, really, really expensive service and enriching all those doctors and building all these ornate facilities that are springing up all around us in a recession, all is under the name of health care. So the political economy piece argument is very closely. I've never gotten a political scientist to agree with me that the tax subsidy has any importance as policy. And when in fact it has changed the voter behavior and consumer behavior in the most fundamental ways and created the mess we find ourselves in.
All right. You know, it's great because, as you can imagine, there's three observations. As you see, there are a great variation in the political sympathies of the panelists. There is widespread agreement on what's to be done, and there's also widespread agreement that what should be done isn't being done. And this is in spite of political dissimilarity. Any questions?
So as a law student, I'm kind of interested in how medical malpractice has sort of affected doctors, whether it's preventative medicine or just, I don't know, just other just ways in which it's affected the patient-doctor dynamic. I was wondering if you could maybe touch on what is being addressed in the current bill or what you think needs to be addressed to correct those problems.
No, but before, great question. Before I want to expose the professional allegiances of the panelists. We have one doctor, one economist, and one lawyer up here.
So as the token physician, so of course I'm going to blame all of the healthcare ills on the lawyers. It's a cheap joke. I had to do it. Actually, it's almost a non sequitur. You know, the malpractice costs in healthcare about 1%. So if we went to an AMA meeting, they'd all get riled up about it. But when you look at it, it's not there. What has happened over 20 years is this concept of defensive medicine, right? Which 20 years ago, we used to try and think about whether we can enumerate what was standard of care and what was defensive. And then we most of defensive medicine ended up being imaging. So I wasn't sure if you broke your neck or not. Instead of getting a plain film for $30, I'll get a CAT scan for $400. And you know what we realized? We got $400 for doing the CAT scan. And we got $30 for losing sleep over the plain film. You know, that was a no-brainer. So, imaging's now about 10% of the cost of healthcare in the United States. And is one of the most variable costs. So where you see, if you guys, if you want to read a depiction of this, read Atul Gawande's thing from the New Yorker, which Barack Obama made everyone read in the White House. So, you know, what you see there is not a variation in the number of surgeries that people are doing. It's how many times a day you get a CAT scan. How many people in this room have had a CAT scan or an MRI? Okay. When I was a med student in New York City, okay, not too long ago, the entire city of New York did not have one MRI machine. And I was a med student at Bellevue. And so for a 1,900-bed hospital, there was one CAT scanner. And the med student's job was to go down in the morning and argue with the radiologist that your patient was the one who should get a CAT scan that day. Okay? So the fact that each one of you had a CAT scan or an MRI, I'm sure for perfectly legitimate things, looking at your age population, it's not like you guys are, you know, doing lung cancer things, hopefully. You know, that's, you know, click it off, $400 a pop, because you had a headache or a twisted ankle or whatever it was that got you the CAT scan or MRI. So that's great business for us. It's not, you know, we'll chalk that up to defensive medicine, but defensive medicine got superseded by the fact that we over-reimburse for imaging. And the other thing about the Atul Gawande piece is it happened in Texas, where the piece is all about this one town where the Medicare per capita expenditure is $15,000 a person, when the average income in the town is only $12,000. And in fact, the rates and utilization in that town are in a state that has malpractice reform. So, so there's something about our ability to generate income through imaging that's independent of malpractice. It's not to say that the malpractice system is efficient or that actually takes care of any of the people who get hurt or, heaven forbid, patients with cerebral palsy. But it's not the cause of the major cause of the problem.
Yes, so I think the costs of defensive medicine are wildly overstated. I also think doctors are obsessed with it. I also think as you move to any kind of attempt to impose evidence-based guidelines, any change you try to impose on how you do medicine, if you don't do something to be seen to have addressed medical malpractice, the doctors will say, but what about medical malpractice? So I think politically, I suspect if a bill is actually signed by the president, it's because he in the end pushes for a medical malpractice that's considered shocking for a Democrat to have pushed for. I think that'll be the last thing that'll bring, if they get a bill that'll bring some of the conservative Democrats in the House especially on board. So overstated, the system's a wreck, it does nothing well. I mean, it's like, could you make a more screwed up system? Probably not. But it won't revolutionize the cost of health care by quote unquote fixing it.
Let me suggest that you think of the law of medical malpractice as another of these regulatory burdens laid on this industry. What it does is to say there is somewhere out there a professional standard of care and every doctor better live up to it or he runs the risk of being sued. And that's a considerable penalty, even if you are sued successfully. It's not something any doctor wants to go through. The problem is that that standard of care doesn't spelled out anywhere. It's all up to some medical expert to come in, and so you know, if this were really a regulatory program in an official de jure sense, it would not pass due process test because the standard is so vague. But what it does is to push everybody, it gives everybody an excuse or pushes, as the case may be. I mean, actually the doctors, as has been indicated, don't really mind being pushed in the direction of spending more. And so these complaints are not to be taken completely at face value. But the result is to push things up. And, you know, I've been arguing for 30-some years now that we should allow health plans to write new rules for medical malpractice, when you can be sued and what the damages would be. The reforms being discussed, I think, are irresponsible. The Republican ideas are terrible ones. The notion of capping non-economic damages, all that does is cut off access to lawyers for lower income people who don't lose much income as a result of an injury. What I think we ought to do is cap economic damages above a certain level so that the rich will have to ensure their own earning power instead of expecting it to be recovered in tort damages. And so, again, all this is in our paper. I mean, but it's an interesting issue, and but I think that the system does, in fact, A, drive, and B, provide an excuse for overspending on things, and a way around that's very hard to find. I like the contractual bypass of the system as a way of doing it, but there may be reforms that one could imagine. But I have not heard the Republicans or anybody offer a very constructive proposal. The best one probably is to allow evidence-based medicine findings to be introduced as evidence in these cases, and so that juries will be advised that it's not just some medical expert's opinion, it's a more general opinion that we don't have to do more in cases of this kind because it's not economic.
Do you think we have time for 2 more questions, maybe? Jamie.
Yeah, there was some discussion about economizing and the type of economizing that consumers could do, particularly if they were aware of the cost of the health care that they're receiving by getting rid of the tax subsidy. What kind of economization exactly do, I guess, all of you see actually happening from that? And is there a problem with the level of sophistication of the average consumer to determine what kind of health care they may really need?
Want me to try that? I mean, it's a huge question and a good one. One way to think about it is to empower the health plan to do more to control moral hazard, access to that premium pool. In other words, to have some rules about who can take money out for what purposes. That means that if you come down with, if you come down with a glioblastoma, that kind of brain cancer that Ted Kennedy had, you might not get the kind of surgery he got. You might just get hospice care, and you might decide that because that will save, if you extend that to comparable cases across the spectrum, that would save significant money, and premiums would therefore be lower, and you might be willing to take a chance that in these desperate situations you won't have access to the hope that the system loves to sell, even when it doesn't really pay off very often. There are other things you can do. You can adjust co-payments. You can provide 50% co-payment for some things, 90% for others. You can other things that can be done. But redesigning insurance coverage with the idea that moral hazard is a problem that should be managed to varying degrees depending on the circumstances, the income level of the enrollees in that plan is, I think, the way to think about it. And how you do that, how you write the contracts. I wrote a book about how to write these contracts. Nobody's written any of them yet. But it's truly a fascinating undertaking to think about how contract could, in theory and then in practice, solve these problems. It turns out that courts are perhaps a little slow to enforce a contract that says you can't have something that the judge would really like to see you have so he can sleep better at night, or she. And so you have this problem that the legal system doesn't perhaps respect freedom of contract in this area, perhaps on the argument that consumers can't make these judgments, that they might make a mistake. You buy cheap coverage today and then want expensive coverage tomorrow. The president's going to allow you to buy into a plan that has richer coverage if you decide you need it later on. But that is another issue. I think that's a big mistake because it would make it impossible to have plans that are richer and not so rich because anybody in one plan wants to upgrade to a plan where he hasn't been paying the high premiums, it would be a problem. But in any event, the question's a good one.
Yeah,
Sorry, Gil.
so 70% of the cost of healthcare go to about 15% of the people. And Clark's right about the glioblastoma. I mean, it's all for catastrophic stuff. You know, the bypass surgeries, cancer therapy. So making you a better consumer about how to go to a primary care physician is going to do not one iota to change the cost of healthcare in the United States. And it's how do we think about that 70%? So one is rationing. Do we want to cut off access to some of those services? This idea of buying a lower cost plan, I mean, to some extent we tried that with managed care in the 1990s, and what we find is a different Nobel Prize in economics. And this is Danny Kahneman's Nobel Prize on prospect theory. So today when you guys are all healthy, you're going to buy the cheap health plan, right? Because you're never going to be sick, who cares? And you know what? If you got sick, you would never take the Hail Mary to do this crazy surgery that Kennedy did. I mean, that's nuts, right? Go to the hospital, go through all the pain and suffering, to have some shot at maybe, you know, being around for another 6 months. You know, I'll go to the beach and I'll have a good time with the money, right? All of you would say that right now. And what happens is, and what this other Nobel Prize is, when your health state changes, when you get sick, all you think about is restoring your health. Okay, that's your whole goal in life, is restoring your health, and the way to restore that, or attempt to restore that, even if it's a very risky proposition, is by going to the doctor and coming here to Duke Hospital and have us do all kinds of stuff to you. And at that point, price is irrelevant, right? I'm going to die anyway. Well, I'm going to go spend as much as I can, even if it's your money. And so consumers, the media harangue against rationing in the United States about these, and they were always tragic cases. Why the 7-year-old shouldn't get liver transplant because they're on Medicaid in Washington State, when Medicaid in Oregon paid for it. You know, shouldn't this little boy or girl, how many times have you seen the thing in the grocery store of someone who doesn't have insurance? Can you chip in for their bone marrow transplant? You know, we as a society really are uncomfortable about the fact that these people are demanding services, and it doesn't make a difference that they signed up for the cheap plan. They're sick now. These are the things they demand. They couldn't have anticipated, this is the parts the courts will have a really hard time with. Every insurance company knows as soon as you get sick, you're going to want this stuff, but none of you know it because you've never been sick. So systematically, we don't have a great mechanism for dealing with it.
One other question? Sure.
One of the issues that's, I guess, addressed in the House bill, the whole antitrust reform for the health insurance industry, removing them from that. Does that have any? Is that just a political chunk, or is it really of any use?
Totally political.
It only came out when the insurance industry started saying that you know, this whole thing may raise the premium cost to ordinary premium payers, and the White House turned around and threatened them with repealing their tax exemption. I mean, their antitrust exemption. Is that your reading?
Well, I mean, yeah, it's beyond the political reading. That is beyond the motives. There's very little that the limited repeal of the limited exemption would do.
There is, you know, to some extent, the debate about the public option is a debate about antitrust, but it's actually, the president, when he was here in Raleigh, presented it as antitrust. In Alabama, Blue Cross Blue Shield has 95% of the market, as if they had an ability to negotiate with the hospitals. The antitrust issue that's driving the cost is the hospital antitrust side. You know, in response to very aggressive negotiation on the part of insurers, hospitals group together. So, you know, if you're a health plan in North Carolina, you got and you're serving people in the Piedmont, you got to sign up Duke. And you know what? We know you need to sign up with us, and we're going to stick it to you. And there's nothing a private health plan can do about that. And so the truth of the matter, the interesting thing about the public option, if we offered everyone Medicare, Duke Hospital said we couldn't afford to provide services at Medicare rates to a public option plan. Victor signed a letter with the other academic medical centers. It's too bad. Who cares? You know, as a society, we're not willing to pay what you want. You know, build a system that can provide care at the price we can afford. But there's a huge antitrust issue now on the provider side that behind all the scenes is driving up the cost of health care.
Barak and I think we may have a solution to that problem, that a private health plan might find a way around those monopolies, but there are an awful lot of them out there. There are medical groups that are really cover almost every provider, in particular specialty, in a community, and then the hospitals dominate so many markets. And that's just a failure of past antitrust enforcement. We can't very well undo old mergers, for example. So we need another way around it. We think we have one. We've got to take it up with Kevin, and he's going to tell us whether it would work or not. But
maybe next time I'll get Victor Zhao to join the panel also. All right, thank you very much.